All right. Good afternoon, everybody. I'm Jeff Connors, the Program Director for Internal Medicine here at the University of Colorado. I'm going to get us started this week. I want to thank everybody for joining us this afternoon for the University of Colorado School of Medicine, Department of Medicine Medical Grand Rounds. We're continuing our series this week on topics related to the novel coronavirus. As always, CME and mock credit is available for this talk using the QR code on your screen right now. That QR code will appear again at the end of the talk. This week, we have speakers from 3 different disciplines who are going to help us understand what it looks like to triage patients with the novel coronavirus through a busy emergency department, what it means to take care of those patients and the clinical management of their hypoxemia and hypercarbia once they're admitted to the hospital, and then finally, how we move these patients out of the hospital once they've recovered, as the vast majority here in Colorado are recovering and across the nation, leading us to another difficult phase in the management of these patients. Our first speaker is Dr. Kelly Bookman. She's a professor of emergency medicine here at the University of Colorado. She's the vice chair for operations at the UCHED, senior medical director of the UC Health Emergency Department Service Line, the CMO of Broomfield Hospital, and the associate CMO for UC Health North Region. Our second speaker is Dr. Abigail Lara. Abby Lara is an associate professor of medicine at the University of Colorado. She's the medical director of our Medical Surgical Progressive Care Unit at the University of Colorado Hospital and the co-director for the Office of Professionalism and Excellence for the School of Medicine at the University of Colorado. And finally, our final speaker is Dr. Anunta Virapongse. She is a MD as well as an MPH. She's an assistant professor of medicine at the University of Colorado School of Medicine. She serves as the director of quality improvement and patient safety for the Division of Hospital Medicine at the University of Colorado, Denver. She also serves as the associate vice chair for quality for the Department of Medicine, the Director of Clinical Effectiveness and Patient Safety Small Grants Program for the University of Colorado Hospital, and is the UCH Physician Lead for the Maintenance and Certification Portfolio Program, the MOCPAP. And so without further ado, we'll go ahead and get started, and I'll turn it over to Dr. Kelly Bookman.
Turning on my video. Okay. Hello, everybody. Good afternoon. So I'm Kelly Bookman, and I am going to walk you through some of the evolution of the decision-making that we've been using here in the emergency department for the last 2 months. 3 things that we were really trying to address, and the things I'm going to highlight in this timeline, are what we were worried about were an upcoming ED surge. We were worried about testing, who to test, and how quickly the results would come back. We were worried about hospital capacity, and we were also worried about PPE. What's the right PPE, and will we have enough? So as I walk very quickly through this timeline of things, keep an eye out for those 4 things that we were worried about. So the first COVID positive patient was March 5th. And it was airborne transmission that we were all assuming and working under. Within a week or so, during that week, we did not have any COVID testing available in-house at all. And so all the testing was going to CDPHE, and they promised 24-hour turnaround, but it actually turned out to be anywhere from 5 to 14 days. Within a week, we moved to enhanced droplet precautions. Notice again, as I'm talking about the things that we were worried about testing, we were worried about PPE. So these are the things that I'm going to point out. There's other things listed in this timeline that I'm not going to call out. Within the next couple of days, we were actually asked to develop ED surge plans very specific to COVID. So as you know, we already have lots of disaster planning done, but we never really thought about what we would really do in this particular situation. So we were developing thoughts about whether or not we would have tents outside. We even ordered tents, which apparently cost $92,000. So then we walked back on that, and we started thinking about using Bruce Schoeffel and things. At that point, the ED volumes had neither gone up, nor, as we'll get to, had they gone down. Within about 9 days, testing did start to become a little bit more available, and they started giving us criteria for who could or should be tested. And so we started developing tools to help us to manage that within the emergency department. So here's an example of our early testing algorithm. It wasn't the very, very first one, but it was the first one we really needed to use so that we could determine who could get tested. So you notice at the top, you had to be symptomatic. If you needed to be admitted, you could be tested. But if we had another etiology at that time, we wouldn't be testing folks. Then the other people who could be tested as outpatients were healthcare workers, PUIs, and then people with high risk criteria. If you didn't meet any of those, you would not get tested. You just had to assume you had COVID and go home and isolate. Here's an example of what the earliest COVID order actually looked like. And this is the beginning of when we started trying to use questions within the order to drive who would get tested. If you didn't answer these questions correctly, you wouldn't get tested at all, or what test would be done and on what platform. And I'll show you some of those iterations later. It's important to remember that early on, we actually thought that doing respiratory viral panels, if you were positive for some other respiratory virus, that you didn't have COVID, that piece changes as part of the timeline. So more timeline, we started developing ways of taking care of intubated patients, recognizing this is 2 weeks into the having any patients at all. So we really didn't have so many patients here yet who were getting intubated. We hadn't seen our surge. We were expecting the surge to come. We started talking about testing first responders, and then we started developing processes to start to address hospital capacity in terms of starting to send patients elsewhere. And I'm going to go back actually to the very top here. On the 16th of March, so 11 days after the first patient was noted to be COVID positive, we here at UC Health canceled our elective surgeries. That was about 2 weeks before the governor said we had to do that. And that was all about managing hospital capacity, as is starting to send patients over to Children's. We were creating marketing things and doing stuff like that. There's lots of other things that were going on during this time. But right around the 26th is when we started noticing that the ED census across UC Health was down by about 40%. So this ED surge that we had been expecting seemed to paradoxically not be happening, which in retrospect makes a whole lot of sense to me, but I absolutely never heard any folks planning or preparing for this kind of thing from a pandemic perspective. And then about 2 days later, a big important piece happened here for us at UC Health. We got the rapid Cepheid testing platform. So prior to this, we were testing on the Roche platform, which is about a 24-hour turnaround time. This Cepheid testing allowed us to get results back in 90 minutes, which allowed us to change how we were making decisions about where patients would go upstairs. Prior to this, we had to send patients up, and if we thought they had COVID, they'd go to a potential appropriate place with negative airflow and using very extensive PPE. Now we were able to not even place an admit order until this rapid platform testing came back as positive or negative. Here's an example of what the COVID iterative test started to look like. This is really the first time, and I guess I didn't mention as part of my intro, but I'm a Epic physician builder and a physician informaticist board certified in that, as well as emergency medicine. So this is the first time we've actually done such extensive creation of orders to try to drive lots of stuff in the background. So we started doing with one order, are you admitted? Are you going to be discharged? Have you traveled, et cetera? And based on your answers, new things would cascade. And based on your answers to that, you would get placed, your test would get placed on a particular platform. So that's actually been very helpful and very complicated. It's been very confusing for providers to try to figure out what they think they're supposed to be doing. And it's been very difficult to actually build because it seems to change maybe every 12 hours. So back to the timeline. This is now about 3 weeks into all of this. This is a change, and this is almost a going backwards, right? So we thought it was airborne, then we said we were going to do enhanced droplet precautions, and now we're saying that any intubation at a system-wide level is going to be done, and I don't know if you guys are actually seeing this, system-wide would be done by somebody wearing a PAPR, a gown, and double gloves. So we actually got more serious about what we were doing instead of less serious. The other thing that was important during this same day was that we recognized that there was significant co-infection. And so we actually stopped waiting for the RVP results because we were noticing that people were having rhinovirus and having coronavirus. So that was a big change in how we were deciding where patients were going to go and when they were going to go there. And then about 3.5 weeks into it, we recognized that there was an opportunity here for us to think about who could be safely discharged from the emergency department. So we began the process of creating what we call our ED pathway for initial evaluation and management, but it was really all being driven about who could we send home so that we could manage our inpatient hospital capacity and not when the surge was coming, because recognize that back then we thought the surge was coming in a week to 2 weeks from then. We know things have changed, but that's what we were planning for back then. So what I recognized pretty quickly was that this was really an evidence-free zone. Things have changed in the last 5 or 6 weeks, and we have a lot more literature. But on that night, as we were starting to try to build this, I remember staying up all night and looking at the literature, and it was very sparse. I called everybody that I knew who was a subject matter expert and asked for their opinion. And people had lots of opinions, but nobody really knew exactly what to do. So we got very conservative, and we created this. So this was our first iteration. We kind of made this up. We thought that everything here on the left maybe would be okay to potentially go home. And remember, we couldn't test them then. So we were guessing that they had COVID, and we were thinking that these sets of people would be safe. We would send them home, and we would not test them. We would just assume that they had COVID, and then they would have to actually manage themselves at home for at least 7 days. And if we thought we needed to do a more of a risk stratification, we thought we would order this litany of tests to try to help us to figure out who would be potentially a sicker person. And the thought was, if all of these things were within normal, then maybe these people, even though they had these high risk criteria over here, potentially could be safe to go home. As you can imagine, everybody hated ordering all of these tests. It felt like a lot, and it really was a lot. But we didn't want to send anybody home who was secretly sick, because we were recognizing that people looked good and then they looked really bad an hour or two later. So back to our timeline here, we have really within 3 weeks, our numbers were so low in the ED, we canceled one of our night shifts, which is a pretty big deal and starting to get scary for people worrying about their jobs and things. We started talking about scarcity, and we started talking about proning patients. And I know, I think Abbey is going to talk a little bit about proning, so I'm going to leave that there. But we were proning awake patients in the emergency department within a month of our first patient. A couple days later, we had some expanded outpatient COVID testing, which was a really big deal because that allowed us to actually test patients and send them out and know that they would actually know whether or not they really did or didn't have COVID. But it was still pretty tight group of people, only the immunocompromised patients and some very select folks, not everybody yet, and certainly not asymptomatic patients. Right around this same time, people were starting to be concerned about the Cepheid rapid test, which is the 90-minute test, and not trusting it. And so we started leading to a lot of secondary testing and not trusting the negative tests. Another big thing that happened to us was allowing for us to get home oxygen. I don't know if folks know how hard it is to get home oxygen, either from the inpatient or the ED setting. It usually takes 6, 8, 12 hours. We were able to contract with a vendor to get us oxygen in the emergency department within 30 minutes. So that was a big step forward so we could send patients home. We developed a resuscitation appropriateness pathway, which allowed us to think about non-beneficial treatments and who would or wouldn't potentially get ventilators and how we could prevent people who didn't want to be resuscitated from getting resuscitated. That went live at a system level. We started sending patients who needed to be admitted to the VA. This is a month into our whole process. We shut down another shift, our morning intake and our super track, which is our urgent care, which was basically decimated during this process. Just to call it out, we were seeing something like 290 patients before all this started, and right around this time we were seeing around 170 patients in the emergency department every day. A layer testing started. This is the point of care Abbott test that was a turnaround time of about 10 minutes. That seemed like that was really going to be a great activity to have. We really thought that was going to help things and break everything wide open. I'll show you in a minute why that was not really so helpful. And that same day, we also removed all acute phase reactants from the pathway, so we weren't ordering anything anymore before we were trying to make decisions for admissions. There were some more shortages in terms of intubating patients. It came out, we did some testing, and we showed that the Cepheid rapid 90-minute tests are as sensitive and specific as the Roche. So people got excited about that and stopped doing secondary testing. That same day, we started testing asymptomatic patients who were going to the procedural areas like cath lab and IR, which is pretty controversial because, as we all probably know by now, asymptomatic patients on any of the tests, even the best tests, are as low as 25% sensitive. So this really wasn't about whether or not the patients needed to be treated with PPE and that sort of thing. It was really about disposition of patients. So that's why I included it in our timeline, because it really changed a lot of what we were doing in the ED. We started removing all of the risk stratification blood tests to a considering order on our pathway. And then we expanded outpatient testing to all symptomatic patients and felt that it was probably safe to send 70-year-olds home. Oxygen recommendations changed, and I will let Abbey and others talk about this, but it changed away from hypoxemia and went to work of breathing, which changed when we were intubating patients. UV reprocessing started. Our layer testing was abandoned because it was abysmal and the reliability was terrible. We went to pre-op and procedural testing for asymptomatic patients just the Friday of this weekend. Then we started running out of the rapid turnaround tests essentially immediately. On Monday, our elective surgeries have resumed, and that brings us to today. And lots of things are already happening today, which everybody will hear about tomorrow. So I'm not going to go through the pathway other than to say, this is what it looks like now. If you remember the first slide, there are about 3 boxes and who we could test and who we couldn't. Now we have a discharge arm, we have an evaluation arm, and we have a pre-op testing arm. And oh, it goes to a second slide. And we have the whole disposition arm with home oxygen, being admitted, and how do you give out discharge instructions, et cetera. So that, in a whirlwind, is the way that we learned how to manage our ED patients. And I will turn it over to Jeff.
It's great, Dr. Bookman. Thank you very much. That was excellent. We have a number of questions for you. We're going to hold those till the end of the talk. I do want to let the audience know, I think I forgot to say this in the beginning, if you have questions for any of our speakers, Dr. Bookman or the speakers that are coming, please use the Q&A feature that is at the bottom of your Zoom screen. Those are being monitored, collected, and then we will ask them at the end. And so now I will turn it over to Dr. Abbey Lara, and Abby's going to talk about what it means to manage these patients, how similar are they to our ARDS classic patients, and what differences we see in their management.
Great. All right. Just give me 1 second as I coordinate technology here. And firstly, I want to thank Dr. Connors for inviting me to speak about my experiences and the unique challenges that I experienced in managing these patients in respiratory failure that's associated with COVID while I was an attending on our surge unit. So to date, we have admitted to the University of Colorado a total of 477 COVID positive patients. Of these patients, 184 required an ICU stay, or nearly 38%. And of these patients in our ICU, 129 required mechanical ventilation for support. It should come as no surprise that if a patient was admitted to the ICU, it did profoundly impact their length of stay to an average of 14 days in total that has implications for discharge. What's listed here is a classification of severity of COVID-related disease that was recently published in Clinical Immunology. I'll be sharing 2 cases, one of severe COVID-related infection, which is defined here as pneumonia with hypoxemia, and critical infection, which is defined here as ARDS with this associated organ failures. However, the organ failures that we were seeing in COVID are beyond the scope of this particular talk. The gas exchange abnormalities that I saw in patients with COVID-related infections are not necessarily unique to the infection itself. It was more specific about the management of these patients that I'll get into. We saw the common acute hypoxic respiratory failure and ARDS, which by far and away are the abnormalities that we managed most commonly. There were a handful of patients that would present with acute hypercapnic respiratory failure, and we also saw that in our ICU more towards the end of their ICU stay as their disease progressed. I'll start with a case of a 53-year-old female who was admitted for supportive care of severe COVID-related pneumonia. She has what's now commonly known are the risk factors for severity of disease, which includes hypertension, obesity, and diabetes. What's listed here is her admitting ABG, for which was obtained while she was presenting to the ED, and a pulse oxemia of 94%. During the first 18 hours of her admission to the floor, on our pulmonary floor, she was actually doing fairly well. Then at about hour 18, a MET was called for rapid clinical deterioration with acute hypoxic respiratory failure. She had rapidly escalating FiO2 needs, and when we arrived at the bedside, she was citing 88% on 15 liters, and she was severely dyspneic. And what's demonstrated here is her chest x-ray that was obtained during her intake in the ED, and what demonstrates is diffuse pulmonary infiltrates. As we were coordinating rapid transport down to our surge ICUs in anticipation of an urgent emergent intubation, we asked the patient to go into the prone position for transport. And within about 60 minutes of her arrival to the ICU, we were able to wean down her oxygen delivery down to 6 liters, and her pulse oximetry stabilized at about 93%. She was observed in the ICU for the following 4 days, and she participated in what we would refer to as a frequent tummy time. So we would ask the patient, oftentimes by nudges from the nurses who identified her pulse oximetry was decreasing, we asked the patient to roll into her belly during the awake hours, and that would stabilize or even improve her pulse oximetry. She was ultimately able to avoid intubation, and she was transferred back to the floor after about 4 days in the ICU. So a question here about high flow oxygen or non-invasive ventilation modes of support. Why wouldn't I have called for this at the bedside? And the reason for that is both heated high flow and non-invasive ventilation modes of support, BiPAP and or CPAP, are known to aerosolize this virus. And the concern with aerosolization of the virus is that it could expose not only other patients during transport, but importantly, the healthcare workers that were caring for the patient. Though we have amazing support from the hospital in regard to a supply of PPE, and we were all utilizing the PPE appropriately as we had our PPE support team that were watching how we were putting on our PPE and donning and doffing appropriately, we still felt concerned that aerosolization posed a risk to patients. So we changed our practice in the bit in regard to these patients with hypoxic respiratory failure. We would ask them to go into the prone position early during transport in an attempt to stabilize their oxygenation. And we also would move towards early intubation as opposed to managing with non-invasive modes of ventilation. This guideline was recently developed with Kyle Molina, who's a PharmD, and Bridget Graney, that provides some guidance in regard to our experience here at UC Health in conjunction with our communication with our colleagues, not only on the West Coast and the East Coast, but also from the experiences from Italy and China. And from a respiratory support standpoint, we make the recommendation that if oxygen is needed to be given to support these individuals, that we simply provide oxygen through the high flow nasal cannula, and avoiding heated high flow or non-invasive if at all possible. In those certain situations in which patients were best supported with non-invasive or heated high flow, it was absolutely recommended that these patients be supported in negative pressure room and on our COVID surge service. And of course, early intubation for COVID-related ARDS patients. So the physiologic effects of prone positioning are well known and well established, and I know Rick Albert, who's probably on this call, has been studying this for the majority of his career. We know that prone positioning improves oxygenation by providing a more homogeneous ventilation distribution, and it decreases the ventral dorsal transpulmonary pressure difference during the mechanics of breathing. and also decreases lung compression. And all these effects are demonstrated here radiographically. This is taken from a figure from Gattinoni's review of the physiology of prone positioning that was published last year. And it demonstrates the changes in the infiltrates going from the supine position to the prone position and back to the supine position. The feasibility of the awake proning patient made some sense to us. Number one, we wanted to try to avoid intubation if at all possible. And number two, because there was concerns about the supply chain and whether or not if Colorado had a huge surge in number of patients that required ventilators, we wanted to make every attempt possible to maintain the number of vents that were available for patients. Self-proning is safe, and it requires very little resources other than having a nurse at the bedside to make sure that the patient doesn't get tangled up. What's listed here are two observational studies that evaluated the efficacy and safety of early proning in the awake patient on both ARDS. The first study that is listed here did not include COVID-related patients, but the second study does include COVID-related patients. And although it's an observational study and should not be used necessarily to change practice in general, but it does offer that the awake prone position of these patients is safe and can be effectively utilized. Interesting point to note, of the patients with a P to F ratio of less than 100 who were also a non-invasive in the first study, ultimately all deteriorated and required intubation, which suggests that severe ARDS patients are not the appropriate patients to try this awake proning procedure. Second case that I want to present to you is that of a 43-year-old male with severe ARDS. He was also transferred to our ICU following an emergent intubation in the ED. Upon arrival to our ICU, his P to F ratio was 110, which indicated severe ARDS, and we immediately proned him upon arrival to our ICU. And again, demonstrated here is his X-ray, which shows diffuse infiltrates. This is very similar to what we are seeing in all of our patients who are admitted with COVID-related lung diseases. The practice of supporting patients with ARDS and the prone positioning is well known, and we provide evidence-based practice in our medical intensive care unit. We've had this protocol in place for proning our severe patients following the publication of the Perceiva trial back in 2013, which demonstrated an impact not only in morbidity but mortality as well with these patients in the prone positioning. We utilize a severity, the Berlin criteria for severity of ARDS, which is listed here as mild, moderate, severe disease. In this particular patient, he was admitted on a Monday, and unfortunately, throughout the course of his disease, despite following the prone protocol with supine and prone positioning every 16 hours, although his clinical course included some improvements, so much so that as we were nearing the weekend, I was hopeful that he was going to be able to be extubated. Unfortunately, over the weekend, he clinically declined. We were able, prior to him becoming worse, to obtain a CT scan of his chest to confirm whether or not there was a PE, as that has been implicated in some of these patients. It was negative, but shown here are his lung windows of his lungs. His P to F ratio on the last day of my week in the ICU was unfortunately 88, and this was despite being in the prone position with other rescue modalities to provide support, so indicating severe ARDS. At that point, I asked for a cardiothoracic anesthesia and surgery consult to evaluate the patient for the appropriateness to be placed on ECMO. And so on day 7 of his surge ICU course, he was placed on ECMO at the bedside and was managed in our Surge 3 team, which was our cardiothoracic anesthesiology team. And what's demonstrated here is effective improvement in his oxygenation with a P to F ratio, which improved up to 164. We have utilized extracorporeal membrane oxygenation as a support modality here at the university, and I think we're one of the our practice here is supported by that because we are a tertiary care center and an academic center. What's listed here is our experience to date, and I appreciate our colleagues, Dr. Hennigan and Dr. Sullivan, for providing me this information. To date, there have been 12 patients that have been cannulated with ECMO. 10 have been decannulated. The age range has been from 24 to 64 years of age, and the gender distribution is listed there. The comorbidities are as expected: diabetes, hypertension, and obesity. Just a short blurb about the hypercapnic respiratory failure in COVID patients. We're seeing it not only anecdotally early in the course and also late in the course. When we see the hypercapnia later in the course, it's to be anticipated as we utilize lung protective strategies to maintain our patients with ARDS that allows for permissive hypercapnia. However, there have been some anecdotes about the observations of an increase in dead space ventilation, and this is a recent case series of 9 patients that is on online ahead of print publication, in which the authors measured the ventilatory ratio of these patients and indicated that there was an increased rate of dead space ventilation that was different from what we would typically see in ARDS patients. Now, what's unknown in this particular case report is whether or not the dead space ventilation is truly related to the pathophysiology of COVID, or if it's simply related to the ventilatory support modes. So finally, I just want to give a huge shout out to the team that I worked with on Surge 4. We were able to provide outstanding patient care, and it truly had impact on our patients. This team was committed to providing evidence-based practice, and although I did show several observational studies, I think the important point here is that we did follow our evidence-based practices as much as we were able to, and we tried very hard not to get caught up in the psychology and the stressors that come with working in the pandemic. And so I'll leave you all with this quote from a perspective that was just published yesterday. In these uncertain times, physicians fall prey to cognitive error and unconsciously rely on limited experiences, whether their own or others, instead of scientific inquiry. We believe that physicians should be acting in concert with clinical equipoise. And with that, I will end and say thank you so much for taking the time to hear our experiences, and I look forward to your questions.
Dr. Lara, that was fantastic. Thank you very much for your presentation. And now I'm going to turn it over to our third speaker, Dr. Virapongse. She's going to talk about the remaining challenge. So, the patient makes it through the ER, they're admitted, they come into the hospital. By and large, like we talked about, they are recovering from this condition, but then getting them out of the hospital safely has become its own challenge. So, Dr. Virapongse. And then you'll just have to make sure to unmute yourself.
Can you hear me now?
Yes, that's perfect.
Okay, thank you. So thank you very much for allowing me to speak on this topic. I've been asked today to talk about some of the challenges that we've seen on the inpatient units with discharging COVID-19 patients. So I work, my clinical work is at the University of Colorado Hospital. And up until a few weeks ago, we actually weren't discharging a lot of COVID-19 patients. And the ones that we were discharging were relatively healthy compared to the patients that we're now seeing. And this is because we're seeing a lot more patients that are coming off the ventilators, thanks to the fine care of my colleagues in the ICU. And also because we're now coming over the Colorado pandemic peak and now into the plateau. So our discharge numbers have definitely risen, and the complexities involved in coordinating the care for discharge have also increased with that. So the different types of COVID-19 patients that we're seeing come in 5 different flavors. The first type of patient is the relatively healthier patient that now has a little bit of an oxygen requirement, and that's the first category. Now, typically, since we live in Colorado, we discharge a lot of patients on oxygen, and that is standard practice. But if you were to go to Boston or Los Angeles, they would not be discharging patients with acute oxygen requirements to home. They would be keeping them in the hospital, but this is standard for us since we live at altitude. However, as Dr. Bookman said earlier, the types of patients that are on oxygen with COVID are different from our standard population. And so trying to establish what stability is was a little bit difficult in the beginning part of this pandemic. The other part that we were challenged with is that if we were sending patients home on oxygen, they had to have some sort of follow-up plan. But obviously, a lot of the primary care offices were now closed. We really didn't have a way for patients to have a recheck of their oxygen levels as an outpatient. Some of these patients also didn't have primary care follow-up to begin with. And a lot of primary care offices were offering televisits rather than actually in-person visits. The final problem was that the availability of home pulse oxygen monitoring wasn't available. They were all sold out from your local CVSs and Walmarts. And so that wasn't an option for a lot of patients. We also were seeing patients that need to go home with some sort of home care service like physical therapy, occupational therapy, nursing care, but a lot of home care agencies were no longer accepting patients who had had COVID. And so we were having to rule these patients out for transmissibility of COVID in the inpatient setting so they could receive these services as an outpatient, which of course prolonged their stay significantly. The third category were the post-ICU or post-pneumonia patients that were very weak and could no longer return home. Many facilities would not accept any patients with COVID. And as of now, we only have 3 facilities in the Front Range area that accept COVID positive patients. We, as one of many hospitals, are all fighting for the same space in these facilities. So you can see that this would be a challenge to try to discharge these patients out. So we are required to do COVID testing to make sure these patients are negative to send patients to any facilities for the most part, and that also prolongs their stay. The fourth category are the patients that are transferred here from other facilities. So as Dr. Lara said, we are a tertiary care center and we receive patients from other areas, sometimes as far away as Nebraska, North Dakota, and they are life flighted here, oftentimes without a way to get home. So in normal circumstances, we have to be creative. We have to get these patients home, so we send them on shuttles, on buses, to get them back to their families. However, with COVID, those options were no longer an option for us. We now require that patients have to return home with private transportation, so they can't take an Uber or a Lyft to their home, even if it's an hour away. So that is definitely a challenge, and our teams have had to be really creative about how to get these patients back home again. The last category are the undomiciled patients. So a lot of patients who are undomiciled do not want to really go to the shelters because they feel unsafe there. They feel like the conditions are unsanitary. And so a lot of patients actually live around the hospital in the parks around. And so this is particularly challenging if they're a COVID patient because it would not be a safe discharge to send these types of patients back to the street without some sort of social isolation plan. The other problem is that many shelters do not take COVID positive patients without making sure that they've ruled out. So their stays are also prolonged as a result of this. So in order to deal with this very new population of patients, we basically had to modify our current discharge processes significantly. And as we considered how we would do this, we really had to think about all the elements that typically go into discharge. Most importantly, we had to develop some sort of consolidated approach because obviously having 5 different processes for 5 different patient populations wouldn't make a lot of sense. Everybody had to know their specific roles, and we had to make sure that we were timing things appropriately. So we had to, if a patient was about to be transferred home with their family who lives 10 hours away, we had to make sure that the oxygen was delivered on time that morning so the patients could then go home. The last consideration was the hospital capacity issue, and Dr. Bookman already highlighted this in her talk. Hospital capacity drives what we do for discharge criteria. If, for instance, we had a surge situation, which we were expecting, we would want to have perhaps more loose discharge criteria to get patients out of the hospital faster. but we would also have to balance that with the safety of these patients going home. So how do we define these criteria and figure out how to surge and flex up and down depending on the situation? Typically, our current discharge processes are more fixed. We actually vary it depending on the patient, but here we have a fixed population with certain criteria that are shared by all. So how can we manage that? So we went back to what we typically do with discharges, and these are the standard decision nodes we use for any patient we discharge. And we ask these 5 questions. Now, with COVID-19 patients, we actually knew the answers to 3 of the 5. We knew where they could go, what things they would need to be successful, and for the most part, what information to tell patients, except for the fact that the isolation criteria were changing. The first 2 questions were more difficult to answer. Dr. Bookman already highlighted this in her talk. Who is eligible for discharge, and what would define high risk or low risk for returning back to the hospital and for morbidity? And as she described already, this is an evidence-free zone. So we went back into the literature and we looked at who else has done this, and most of our data is from other countries. So we have China, and these are their discharge criteria that they used, Singapore, and we have Italy. And you can see that all 3 countries have very different discharge criteria. And this was really dependent on what resources those countries had to understand how ill these patients were. You can see in Italy that they don't have imaging as part of their discharge criteria. And this is probably because they really didn't have those resources to re-image these patients at the time of discharge. As far as what we're doing here in the United States, looking at national guidelines, these are the CDC recommendations. They go into detail about what we do for empiric transmission-based precautions and discontinuation of them with a test-based strategy and a non-test-based strategy. But when we go to what we do for discharges from healthcare facilities, this is what they say: whatever is clinically indicated. And for us trying to develop a discharge process, we had no idea what this meant. So going back and looking at what other hospitals are doing across the country, I belong to a research collaborative called the Home Run Collaborative, which is run out of the University of California in San Francisco. And they've started to do a survey of academic institutions throughout the United States. This is very preliminary data. So far, they have some information from 11 academic institutions. And you can see that not many institutions are using specific clinical criteria for discharge to home, only 3 of the 11. Same for whoever goes to SNF or assisted living. Very few are using any sort of telemonitoring capabilities, and only 4 of 11 actually are providing patients with masks and gloves and things to continue to do social distancing and isolation at home. So a lot of variability in what's happening in the nation right now. And again, it goes back to the fact that this is a giant black box that we're still trying to gather data about. And if I were to go back into the literature, and I've been doing that the last few days, there really just isn't a lot of data out there on readmission rates of these patients. So we decided to build a pathway similar to what the emergency room has done. We can look at this timeline and we can see that in March 18th, we actually went live with a diagnosis and management pathway. And then on April 2nd, the Division of Hospital Medicine at University of Colorado Hospital went live with a discharge pathway. And then subsequent to that, 15 days later, the UC Health system took our discharge pathway and went live with it across the entire system of 13 hospitals. So I'm just going to run through the inpatient discharge pathway really quickly. I'm sorry that the resolution on this isn't ideal. This is the best I could do. But if you look at the first part of the pathway, you'll see that first yellow box. And in that box, it actually tiers the approach into a high risk and low risk category. You can see that it divides it up by age, but also by the number of hours they've been afebrile. The other thing we added to this box was inflammatory markers, because we understood that if a patient had already gone through the systemic hyperinflammatory systemic process, and that cytokine surge that we all know about, they would have downtrending inflammatory markers. So rather than utilize testing to determine if a patient was clear, which wasn't a good marker for stability, we used the inflammatory markers instead. The other thing we used was the fact that, the other thing that we did was we added that oxygen criteria. Going down the pathway, you can see here that we've now added a section about subacute rehab, home care services, and what to do if they're in domiciled. Again, we added those criteria that we discussed earlier. The other key part of this pathway that is new is the VHC criteria. So for high-risk patients, our virtual health center is now doing remote monitoring of high-risk patients at discharge. This is a pilot. We're currently doing this on 50 patients on the inpatient wards, where we are giving them a bracelet called the Massimo bracelet that will monitor heart rate, respiratory rate, and pulse ox. And it will send that data through an app that the patient has on their phone to our VHC center. And the virtual health center will then call the patients daily to make sure they're doing well. And then if anything happens with those vital sign monitoring, they have an escalation plan in place to help those patients and get them into the emergency room or get them help as soon as possible. So this is a pilot, and we're hoping that this will be spread to more patients throughout the UC health system in the coming weeks. And honestly, it's actually a very innovative process that we can actually use for more patients than just COVID patients. So the one thing I want to highlight is that this process has really stimulated a lot of innovation and change on the part of our system. The last part of this pathway is the discharge orders. And as part of this, we actually built a discharge order set for COVID patients that our providers can access to the Discharge Navigator. The instructions include medical student callbacks for follow-up for all the patients that can't get the VHC monitoring. And in addition to that, it includes isolation recommendations, recommendations for follow-up with pulmonary and infectious disease clinics with those criteria, and also patient instructions. So how are we doing? Well, the best way to monitor this is to look at our readmissions. And this is data from April 25th. And this data was provided me from my colleagues, Claire Brixon, who is a PGY1, Tara Ward, and Imran Bajashvili, who's one of the hospitalists, or both hospitalists. So our total discharged COVID-19 patients are 264. Of these, we had 12 readmissions. That's 4.5%. That's an all-cause readmission rate. When we dug down a little bit deeper, 8 of those were COVID-related. Of those, 1 had worsening pneumonia. 2 were preventable, but really only 1 was preventable because the pathway didn't exist for 1 of them. The third one, 3 of them had complications that were not covered by the pathway, and we're currently working to add those recommendations for VTE prophylaxis. And the 1 with encephalopathy may or may not have been related to COVID, and 2 were false alarms. So what I can take from this data so far is that our discharge pathway, again, based on best evidence, expert opinion, is working. But data is still continuing to be gathered, and we'll have more to come the next following weeks as we go on. So what challenges do we have? We still have several. We still have to work on trying to place these patients in a cohab, in some sort of situation for the COVID positive patients. Right now, our PM&R colleagues are building or are accepting patients that are COVID positive to a COVID unit. So that's really great. That's happening over this course of this week. We also have limitations to what we can do for telemonitoring. Patients are being lost to follow-up, and so we're still working on what to do about those. And we're also trying to streamline our transitions of care to getting these patients to some sort of primary care. But we have a new pathway that we're currently building to address this. So I'm really here as a representative of many, many people, and this has really been a huge team effort. I also wanted to thank David Schwartz, who couldn't be here today. He's actually attending on one of the COVID services, so special thanks to him. And thank you very much for allowing me the opportunity to present on what we're doing in the Division of Hospital Medicine for these patients.
Dr. Virapongse, thank you very much. That was wonderful, and you covered a lot of ground there. We have over 400 people on the call, and we have many questions to get to. So I'm going to go ahead and hop right into that and try to ask questions of each of you in the time that we have remaining. I'll go ahead and start with Dr. Bookman. So Kelly, you talked about the idea of awake proning being done in the ER. What's the evidence that drove your decision to try this, and what was your personal experience with how these patients did?
It's a good question. As Abbey actually put out one of the observational studies, in our evidence-free zone, we were struggling to figure out how to prevent patients from getting intubated, and we kept following the rules around intubate early, but this stuff is gut feeling as opposed to evidence-based. At least it has been in these last 4 to 6 weeks. And we just started trying it. And when we tried it, we actually saw patients were dramatically more comfortable. And anecdotally, it prevented us from having to intubate those patients before they went upstairs. I don't have any anecdote about whether or not they then went on to get intubated later, but at any amount of time you can prevent these folks from getting intubated, and give them more time to talk to people and be with their family, I think it was worth it.
That's great. And then a follow-up question that was posed to Dr. Lara is that, awake proning somebody is free or relatively free. It may have morbidity and mortality improvements. Is there any reason not to awake prone someone? What are the harms to trying this intervention?
Yeah, there's actually very few harms in attempting an awake prone patient. You do need to have somebody at the bedside that can watch them. The patient should be on telemetry. You don't want the patient to be twisted up in all the lines, the plastic tubing for oxygenation, the telemetry lens, etc. I think one of the challenges that need to be taken into consideration is that there have been some anecdotal reports about the cardiac arrhythmias, and if the patient has any hemodynamic compromise, there really should be a team that is prepared to help the patient. But the risks are very, very low in the vast majority of patients who are admitted to our floors. And those patients who have rapid deterioration from an oxygenation standpoint, and we're making every attempt to avoid intubation, bring them down to the ICU so we can monitor them more closely is always is in the best interest of the patient, and we can rapidly tag into our anesthesia team who has been providing us outstanding support in intubation of these patients.
That's great. I'm going to switch topics here. We have a question. I think this concept of virtual home monitoring got people very excited. So for Dr. Virapongse, how technologically inclined do patients have to be themselves to use this bracelet monitoring system? Is there a cost to the patient? Will insurance cover a service like this? Can you tell us more about that?
Yeah, so that's a really good question. And these are all things we're trying to work out as we're piloting this on the inpatient wards. So the current criteria for our VHC remote monitoring program is the patient must speak English and Spanish, and they have to have a smartphone. These are obviously huge challenges because there are a lot of patients that don't have either of these 3 criteria. We are not requiring that patients have insurance to do this program, but we do have to be able to contact them, and that is a huge challenge. So again, we're trying to work these things out on the fly. They are difficult, and we've seen so far that we have a lot of patients that are speak actually very rare languages that are coming in with COVID, and those are patients that are high risk, and we really don't have a good way to monitor them yet, but we are hopeful that we will soon.
And just a follow-along question to that, what fraction of discharge patients are getting this intervention? And I know you said it was in the pilot phase, but do we know how many of them are being seen in this manner, and how many of those patients have had additional interventions because of what the bracelet is told?
We don't. Again, this is week 2 of this intervention. We tested this on 10 patients last week, and the thing that we saw the most is that patients were having difficulty with home oxygen. I think a lot of us really forget that when we are having to have this new treatment, oxygen, it's really foreign to a lot of patients to now have to carry on a tank. Some of them weren't actually able to get oxygen. I think it's just a matter of communication. I think it's really highlighting now what's happening after we're discharging patients, because now we can see it because we're seeing that on follow-up. But it's going to be really hard for me to say who would be a candidate as of now, because our criteria for who can get it is still pretty stringent. And as far as the numbers, I mean, we only have it so far, 10 patients last week, piloting on 50 patients this week. So again, really hard to say. We're going to see how it goes.
It's very interesting. I want to hop back to Dr. Bookman. It's a question about pathways. And obviously, you know, pathways are things that are part of all of our lives at this point. Their consensus on how to manage these patients, since it's a new disease, changes very quickly. How often do you go back and make changes to your ED pathways?
We have been updating our ED pathway at least once every 24 hours, pretty much since it went live. This is so rapidly evolving. Things about whether or not you do something clinically to a patient or just changing the name of an order. We went from having one order that's an ambulatory order to another. So each iteration of all of those things, that has to update every time. We've been doing that with the inpatient pathways as well. People probably have seen we have about 5 COVID pathways, and they're all being iterated hourly.
And there was another question, and you may have answered it with the hourly comment, but concerns from your group about blunting effective interventions, that it might take too long to get an intervention that's seen effective elsewhere in the world or in the country into one of our pathways.
Yeah, so that's one of the great things, not to get too techie about it, but one of the great things about this platform that we're using, while it looks like it's in Epic, it's actually a partnership with a vendor. And so we have access to the authoring tools, so we can sort of get around some of the long committee after committee decisions. And as soon as something comes out and we have consensus amongst the subject matter experts that it works, we can put it in the pathway within 5 minutes.
Great, thank you. Dr. Lara, a question for you. There are a number of queries about clotting in COVID-19, and I think that's something that we're all talking about at this point. And 2 of them that seem to come up frequently here within the audience. Can you talk about the idea that embolisms, pulmonary embolisms, are a major driver of either the increased dead space or hypoxia within these patients? And then also the question came up about clotting within the brain. The number of patients that are being reported, especially out of Sinai in their 30s and 40s, who are having strokes. Is that something that we're seeing in Colorado, and how are we addressing these clotting challenges?
Yeah, so great question. Yes, there has been lots of conversations and anecdotes about an increased thrombotic risk in these patients. I think I would advocate for the idea of recognizing at the bedside if an individual has clinical indicators to evaluate for a prothrombotic state, that we absolutely should. Now, the question remains still whether or not these patients are at an increased risk relative to other patients in the ICU. So I think studying this is one of our responsibilities working in the academic center. And I do know that there have been a few research proposals that have been put forth through our prioritization committee here at the School of Medicine. And so we will be studying this shortly, and I think that's really important. I think anecdotally, it's very hard for me to share with you after a week experience that I saw an increased risk of thrombotic events in my patients. But did I evaluate them when clinically indicated? Absolutely, just as I showed on my severe ARDS patient. In regard to the risk of increased stroke that we're seeing reports out of, I don't think that we've seen that experience here at the university. I think the important aspect of the critical care medicine and an evidence-based approach to taking care of these patients has been to utilize our sedative medications in a fashion that allows us to do daily awakening, so that way we can do our full neurologic exam. And that should be sort of front of mind as we're hearing these reports, and we'll follow up with studies as clinically appropriate. But again, I think in the absence of having very clear research studies, it's hard for me to say one way or the other, are they at risk, are they not at risk? So I think deviating from my usual clinical practice in the absence of evidence was something that I certainly attempted to avoid as much as possible.
Gotcha, thank you very much. And there's a follow-up question that came in, which makes a lot of sense, which is that not everyone thinks about dead space all the time, and you don't have a whiteboard available, though I guess you probably could do it on your Zoom there. But can you explain a little bit about dead space? It's sort of a brief what it is and why does it matter in these patients?
Yep. So what dead space is when you take a breath in, and it's where that breath goes in your lungs that does not have any perfusion that's associated with that, or blood that is crossing by where your breath is in order to absorb oxygen or diffuse the carbon dioxide. And so when we think about where the areas in the pulmonary tree that are typically associated with dead space, so that's your trachea and your bronchi, which do not contribute to ventilation or gas exchange in the lungs. In patients with ARDS or lung injury, we see increases in dead space ventilation in areas of shunt. So if there is no ability in order to, sorry, I just need to shut off my updates. It suddenly decided to come on. Timing, yes. And so it's in those areas in which there is not any perfusion around an alveolar gas exchange unit, and so therefore can't contribute to gas exchange. The pathophysiologic drivers of increasing in dead space can include just diffuse alveolar damage that we do see in ARDS. Atelectasis can also contribute to dead space ventilation as well, PEs, etc. It's important in these patients simply because we are seeing some hypercapnia in these patients, both in the early process of the disease and the late support as we are providing them lung protective strategies. The reason that's important, and it's important in all patients who have ARDS who are on the ventilator, is that hypercapnia causes systemic acidosis and is associated with its mortality. So therefore, we should be monitoring for severe acidosis and adjusting our ventilator as appropriate.
Great, thank you very much. Dr. Virapongse, a couple questions here about, and I think you mentioned this in your talk, the sensitivity of the various tests that we have available to us, and then how we use those in terms of helping us discharge patients. And then on the counter, as we start to open things up, how we use them to decide who can get surgeries, who can come in for more elective type procedures. How are you using that test in terms of discharge? If it comes back positive or negative, how does that affect what you do with the patient?
So, most of these tests with these patients are coming back positive. So really the discharging pathways and everything refer to positive COVID patients. In our experience, our sensitivity for the COVID patients that we have been testing for positive have been really good. And we've had negatives and we've been fearful of those negatives being false negatives. But whenever we've retested them, those tests for the majority have been tested as negative. However, if we have patients that we have a strong suspicion might still have COVID, regardless of what the test, we will still treat them like they are COVID positive and still make the same recommendations and go down the same pathway as if they did. So that is for patient safety, also the safety of those around them and the facilities. And so we want to make sure that even if we don't completely trust the testing, we're still doing the right thing for the patient and others. And I'm sorry, the second part of your question?
I think the second part was what you do when those tests come back. So if you get a negative, does that mean, and I think the question asker is wondering, does that mean you can then comfortably discharge that patient out into the world? And if it turns positive, how long do you then have to wait to get another test?
Yeah, so and I think that second question, as far as the testing of clearance, I think is what they're trying to get at, is a really difficult one, because we're seeing patients that are shedding the virus after coming out of the ICU up to 2 weeks afterwards. And this is the same that we're seeing in China. You'd have patients who would test positive one day, and then you test them again the next day to try to get those 2 tests within 24 hours to try to get them out to a facility, and the second test would be negative. Then you test them again and it would be positive. So it's this shedding is really variable. Some of that has to do with how we're obtaining the swabs. But this has really been, and I'm not the expert on this. This would be more for our infectious disease colleagues to understand, to really talk about the details of that. But we're seeing that a lot with a lot of these patients where they're testing positive one day, negative the next day, positive the next day, positive the following day, and then negative the next day. And we're continuing to test. You can see how that's really wasting a lot of testing resources to do that. But this is what we need to do to get them out of the hospital to facilities. So it's challenging for sure. And And as far as the inflammatory markers and how they play a role, we think the specificity of those is actually really good in trying to determine the inflammatory response. And so we do trust when they're starting to trend down that those are real. And we're using not just one test, we're using a panel of tests to make that decision.
That's great. And this may be more of an infection control question, but since you're involved in the use of testing and the establishment of pathways, do you have any sense of how we're going to use these pathways to open up surgeries and open up more elective procedures?
Do you want me to answer that, Anunta, or do you know?
Yeah, I think Kelly would be more appropriate to answer that because she's involved with that piece of it.
Yeah, so I think the concern, right, is that asymptomatic patients, when you test them, the sensitivity can be as low as 25%. So it begs the question, why would you test anybody who's asymptomatic, which is exactly what we're doing with pre-op patients. A lot of this is, just to be straightforward, a lot of this is political, and in this sort of evidence-free zone, this is sort of what we have to do in order to make patients feel comfortable and feel reassured, even though clearly the science is not and really there to make it feel safe. What we're really using these tests to do is not to decide whether or not they should or shouldn't be operated on, nor to decide whether or not we do PPE and appropriate PPE in the operating room. It's really to decide what their disposition is post-procedural. So if they come back positive, they go to a COVID unit. If they come back negative, they don't. Recognizing that there's still the issue around the sensitivity and the reliability of it. It's a really an imperfect process.
Yeah, it is very difficult. Dr. Bookman, another question for you, although going back to the ED, it looks like in Colorado, at least, that we're entering the plateau phase of this disease, which means it's going to be out there for a long time, could be many months. How is ED monitoring of patients going to change during the plateau phase here in Colorado? And when do you expect things to return to a more normal state for your group?
Boy, if I knew that, I would love to know the answer to that. Right now, I don't think anything's going to change at this point. At some point, when we get all the testing that seems to be being promised us, then we'll have a better sense of what the prevalence is out there in the community, assuming that some of the sensitivity actually goes up for asymptomatic testing, which is a big if. The EDs right now are seeing a tiny increase with their patients coming back, but a very tiny increase. There's a lot of public service announcements going on out there because what we're seeing is patients are staying home and getting sicker. So they're so afraid to come to our institutions because they think they're going to get COVID that they're staying home and they're perforating their appendix and they're letting their gallbladders go gangrene. They're having their strokes and completing their strokes at home. Same thing with their STEMIs. So there's really a lot of work out there trying to reassure the public that it's safe to come back here. So I don't know if that's exactly an answer to what you asked, but that's what we're doing in the emergency department and out there for public facing communications.
Yeah, I think that does cover it. And I think there was another question about, this idea that things seem to have dropped off. And I think maybe if you want to comment any more on that, which is why we're not seeing as many heart attacks, why we're not seeing as many gallbladders. Do you really think that is that many of these patients are just staying home through what would have brought them into the ER previously?
That is what we think, and that's what we think nationally. And we're seeing nationally that it's not just here in Colorado. Nationally, emergency department volumes have dropped, EMS runs have dropped, and then acuity has gone up. And these things that we would never have seen before because patients came in early, they're letting them linger. So we're seeing much more DKA, worse DKA, that sort of thing. We are not really seeing a plateau exactly yet in Colorado. So I want to be a little bit careful with some of these changes and people going out and things. We're seeing a slight increase. It's in the plateau phase, but it isn't really headed down. So we're cautiously optimistic that we'll live in this plateau. I am a little nervous about seeing a surge with the relaxation of our safer at home tiered event that just happened this week. So we'll see.
Great, thank you. Dr. Lara, I want to ask you about some of the outcomes in terms of patients who have either acute hypoxemic or acute hypercarbic respiratory failure. It seems like from what you described, the question questioner wants to know, it sounds like our data, the results are actually pretty good in terms of overall recovery. And obviously we saw this week some pretty poor data from other health systems. Are we doing better than the average? Are we doing the same as the rest of the country? What do you make of the data that we're seeing?
Yeah, and I think it's hard to make an absolute comparison between our center and other centers across the country for a variety of reasons. The first reason that I would say is I think that compared to our colleagues on the East Coast and the West Coast, we really had the opportunity to learn how to establish our surge teams, establish our protocols and our processes to put them into place based on their experiences. So we were more prepared, I would say, and not sort of trying to get these into place in the middle of things. Number two, the work is still ongoing. So of course, I have a bias, and I would say that our healthcare teams here, University of Colorado, are providing outstanding care because, well, it's the University of Colorado. But I do think one of the impacts that the practice that we've been utilizing is to be adherent to our evidence-based practices and not get caught up in the psychology of working in a pandemic that can be very emotional. So whether or not that has had the impact on our really fantastic patient outcomes, it, I think, still remains to be seen, but I would say that that would be the cornerstone of why we are seeing some differences.
Great, thank you. Dr. Virapongse, the difficulty in getting some of these patients out is, not lost on a lot of our providers as we see the numbers rise, even though, as Dr. Bookman said, cases are not rising particularly fast in the state of Colorado. Is there any thought to establishing long-term acute care within our health systems, within the various hospitals, to try to solve that problem of needing to send patients out to a world that is not necessarily ready to accept?
Yeah, and Kelly can certainly help answer this question too, since I know she's intimately involved in these conversations. But I highlighted in my talk that we're really trying to corral all the resources that we can to try to figure out long-term solutions for these patients who are persistently COVID positive or don't really have a good disposition plan. And so some of the ideas that have come up are using Highlands Ranch for that. We also, as I said, our PM&R colleagues have opened up the inpatient rehab to some of these patients who are still on the acute care floors. Also trying to utilize other hospitals to see if they have resources available. So yeah, I mean, I think the state of Colorado itself, I know, is also working on this. The Colorado Hospital Association is trying to address this very problem. So I think we're lucky in that the peak of this, if we've gone past the peak, we didn't overutilize all of our healthcare resources, so we're able to make these plans. But yes, we are certainly thinking about what our long-term solutions are going to be, because I think that the questioner is very correct in thinking what is going to be our long-term solution, because a lot of these patients, unfortunately, are coming out of the ICU with a tremendous amount of morbidity that's going to be long-standing. Kelly, you want to add to that?
Oh, I think you covered it.
Let me ask another question that could either be for you or for Dr. Bookman. It's about antibody testing. Obviously, a very hot topic right now. Any plans to integrate antibody testing into our discharge process? And is there any utility that you see that you think, boy, if this test was working right now, we would love to have it?
So I can actually speak to it. So we have validated our antibody testing. The reason it's taken us a while to get there is because they weren't trustworthy. We wanted something that was 97, 98% sensitive and specific. We are there, and we will be beginning tiered testing of healthcare workers. So that's coming in the next many days. So that's really exciting. We have to be very cautious, though, to think about what it means. It doesn't necessarily, we don't know what it means, right? It means that at some point you were exposed and that you have antibodies, but we don't know if that means you're safe, if you're immune, if you can't get it again. So the messaging is really, we're going to test so that we can get a sense of what the prevalence of exposure has been, but we're not going to make any decisions around patients or healthcare workers working or not working based on these results at this point. But it's coming quickly.
And there's another question here about, our hospitals versus our health systems. And, obviously a lot of the people on this call work at many different hospitals across Denver. When we talk about antibody testing, are we talking, when you're answering that question, are you answering it in terms of what we're going to do at UCH, or do you think this is going to be citywide?
So what I'm describing is UC Health and what we've done and created for UC Health. So not necessarily UC Hospital alone, but our hospital system. I'm not as aware of what's going on at the different like SCL and HCA and how far along they are in creating their antibody testing and having availability. UC Health has pretty much been first in getting a lot of our testing. So I think we're a little bit further ahead, but it's going to come nationwide.
Great, thank you. A couple of the clinical questions. I think we'll start with Dr. Lara, if you don't mind. The bromide, a dry lung is a happy lung. I think everybody's heard that through their medical training. Results of the FACT trial bore that out.
Mm-hmm.
Does that seem to apply to these patients? And with the reports of renal failure being a prominent feature, does that make it more difficult for you to try to dry these patients out and drive that ARDS away?
Yeah, so that's great. That was one of our big teaching points in the ICU when we were on. So absolutely, the FACT trial being evidence-based practice for management of ARDS, a dry lung is a happy lung. But we have to recognize that when these patients are admitted to a hospital, they're coming in a very pro-inflammatory state. They have fevers. They are not feeling well. They haven't been eating very much. They might also have the diarrheal illnesses. So they're presenting to us with ARDS, hypoxic respiratory failure, and oftentimes in the ICU and septic shock. So we shouldn't be deviating from our usual clinical practice, which is to volume resuscitate our patients based on septic shock, but be very realistic and recognizing that the impact of over volume resuscitating can have on our patients. We know that too much volume can actually be harmful. So what we did in our ICU was monitor the volume status very closely. We evaluated on a daily basis, and oftentimes more frequently than just daily, what their renal output was, your urinary output, and their serum creatinine. So that way we would avoid further injury. Now, what the cause is of their kidney injury, there's all sorts of theories and physiologic possibilities there. Could it be related to a pro-inflammatory state from the COVID? Not sure yet. We still have to wait for the evidence to support that. Could it be pre-renal injury, ATM from septic shock? Absolutely. But I think, again, I keep going back to the idea of making sure that we have common sense approaches that are evidence-based practices for taking care of these patients.
That's great, thank you. And this question probably is for yourself and Dr. Virapongse as well. And it gets to the idea of this increased encephalopathy and delirium that folks are feeling when these patients come out of the ICU. And the person asking the question, said that in their opinion, as best they could tell, it seems like there's a prolonged mental status recovery in these patients. And even when they account for the fact that people are getting higher doses of sedatives to avoid self-extubation, it still seems even beyond that. Are you both seeing this in your patient populations? Do we think this is a COVID-associated neuroinjury, and are we doing anything different for these patients?
So I think, a lot of it is a little bit anecdotal. I mean, I think that I've seen a lot of patients come out of the ICU that have been delirious just in my general population. And in my personal practice, I really only saw one patient with a little bit of encephalopathy, but that did go away after a few days. So I think that is one of those, put it on the list of things that we're just finding about COVID, along with COVID toes and the COVID neuro findings. I mean, there's so many things that we're still discovering about this disease process. So I think that there needs to be more, unfortunately, observational studies at this point. We don't have any sort of comparable trials. It's just still so new. So I think that the more that people are reporting out these cases and we're having better understanding, we'll find out more. But yeah, a lot of it's anecdotal still, and from what I've seen.
And Abby, on the front end, do you feel like these patients are different when you're seeing them in the ICU and you're getting them out to the floor?
I think the short answer is not necessarily, I guess. They are requiring, in my experience, we're requiring similar sedation dosing as our usual ARDS patients. I think the things that I did see that was different was the amount of cough. They had just an increased propensity to cough that would cause some hypoxemia. So in those situations, would I provide them sedative boluses more so than a standard ARDS patients? The short answer is yes. I agree with Anunta. I do think that it's anecdotal at this point. I think there's a perception that maybe it's happening more simply because we're taking care a lot more of these patients. In a usual medical intensive care census, you'll have a handful of ARDS patients and a handful of end-stage renal patients that are coming in with volume overload and et cetera, et cetera. My entire census of 16 patients were all ARDS patients. And so I wonder if there's a little bit of that concentrated effect on that experience that we're seeing. We do know that septic shock does have the propensity to cause some cognitive encephalopathy. Is it at a different rate than others? I just don't know the answer to that yet.
Fair enough. There's a few questions here that may end up with a similar answer, but people would like to hear your opinions on muscle weakness. Similarly, there's a perception that there may be more critical illness myopathy, or at least more ICU myopathy effect in these patients as compared to your standard ARDS patients. So maybe Dr. Lara first, and then Dr. Virapongse, your opinions on the critical illness myopathy in these folks.
What I will say is, again, very anecdotal, but I do get the sense that our patients are intubated for a longer period of time than some other ARDS patients. So that's one. The longer time that you are critically ill, the more likely you are to come out with some critical illness polyneuropathy. The other aspect of these patients, and we haven't really been talking about this a lot yet, is it's very hard to feed them using their GI tract. They have a very delayed gastric peristaltic mechanism for unclear reasons. I do know that there are some reports that are coming out. And so I did find it a lot more challenging to maintain their caloric intake because of that. We had a lot of ileus in our patient population. So could that feed into these patients being more critically ill and more weak? I would say that that's probably going to fare out in the literature as being unique to this particular patient population.
And Dr. Virapongse, from your perspective on the back end, getting these patients out with the weakness that you're seeing, what's your impression of that?
Yeah, I'm kind of reminded of that proverb about the blind man feeling the elephant, and that's what you're feeling is what you see is you think an elephant's made up of a tail. So, we are seeing some of these patients with prolonged weakness because they are in the ICU for a prolonged time, but we also work in a tertiary care center where we're seeing a lot of patients that are really critically ill coming out of the ICU all the time. So I honestly don't think I've perceived a difference in the weakness of patients coming out of the ICU percentage-wise. But again, very anecdotal, very early on. I think we have to have someone really sitting down and running pure numbers to see what our proportion of patients that are being sent to rehabs and their prolonged ICU myopathy is over the course of weeks to months to really perceive what that number truly is. But working on the wards in my own little silo, I did not personally perceive a difference.
That's great, thank you. And there's a perfect transition into a question here about how we are tracking these patients. And so maybe we can start with Dr. Bookman and just walk through our speakers. Given that everything is so anecdotal, what are we doing to add to the general body of evidence? Is there some uniform way that we're trying to figure out what these patients look like from the start to the finish?
So the short answer is we are doing, there's multitude of research studies that are either already going and are ongoing or are being started. And I am not the expert to tell you the litany of them. And I don't know if Abbey or Anunta is, but there's a lot of things that are starting all the way from the start, from the second they walk into the emergency department, all the way through discharge. And I'll leave to Abbey and Anunta if they want to elaborate on some of them. But our vice chair of research continually has been giving us an update on all of them. And it goes from hydroxychloroquine all the way through how we're oxygenating, how we're doing all of our our interventions.
Yeah, but from a clinical research standpoint, the patient outcomes, so number one, there are all sorts of clinical research that is ongoing in regard to interventions and treatments for COVID. In following these patients long term, an assistant professor of medicine in our division, Dr. Sarah Jolly, she's developing a multidisciplinary post-COVID ICU clinic in order to be able to evaluate these patients in the outpatient standpoint. So that way we will truly have that continuum of the natural progression of this particular disease, which I think is going to be critically important to not only improving patient care, patient outcomes, but also informing us about what to expect from these patients.
Yeah, so this is like a whole nother talk. So in my role as Director of Quality for the Division of Hospital Medicine at the University of Colorado, we have, that is one of our major concerns, or what are our ultimate patient outcomes, particularly as we're implementing these new interventions, and building a pathway is a new intervention. So we have been the last few weeks building a patient database of patient characteristics, particularly focused, as I kind of highlighted in my talk a little bit, about whether or not there are any errors in what we're doing for admission criteria, not admission criteria, but our transfer to ICU times, as well as what we're doing for our discharge criteria within the pathway. So looking at readmissions is one of those outcomes, trying to figure out what are the percentage of patients that are going out with oxygen, what are our patients that are mortality. We have to thank our data team. We actually are pretty lucky in that we do have a data team within the division that is building these databases constantly to try to really look at what we need to do to modify our current pathways to fit what we're currently seeing. So the databases contain all sorts of elements, again, go into lots of details, but really we're doing this from a quality improvement perspective in hospital medicine. Maybe later on the line we'll use that for research, but we want to use that data to modify our pathways to make sure that we're making patients safe. So that is the purpose of what we're doing.
Great, thank you. Question maybe for Abby, and then I think we'll have time for one more. We'll end with Dr. Bookman. Dr. Lara, are the University of Colorado hospitals part of, and this could be any of our hospitals here, part of the remdesivir trials? Obviously, a little bit of exciting news this morning that's making its way across popular news media. Are we part of the remdesivir trials? Is there anything you want to add to what you've seen in your experience with those patients?
Yeah, absolutely. So yes, we are part of the remdesivir trial, and we have been part of it essentially from the start. We have been enrolling patients. There are specific inclusion criteria. So we're very excited about the possibility of that being a potential therapeutic intervention. We are also part of a couple of other trials as well, the sarilumab or the anti-IL-6 trial in these COVID patients, the ORCID study, which is a pedal network study, which is going to be randomized as a randomized control trial in regard to hydroxychloroquine or Plaquenil as a potential study. And then, of course, we're also part of the convalescent plasma trial as well.
Great, thank you. And then I think we'll take the last question here. And Dr. Bookman, it's also a question related to the use of some of these different therapeutic options. Are there any drugs being trialed in COVID patients that are started in the emergency department? Somebody would like to know if there's anything that we're using early on in the course of these patients, and do you have any sense of whether that's helping or not?
So the answer is no, we're not starting anything other than resuscitation measures. There was talk at some point about hydroxychloroquine, obviously not doing that. There's probably the only thing that we're really even thinking about doing is potentially early use of anticoagulants, which we have not started yet because we just don't have enough actual best practice evidence yet.
Great, thank you very much. Well, seeing that it is 1:30, we'll go ahead and end here. I want to thank all of our speakers, Dr. Bookman from the emergency department, Dr. Lara, one of our pulmonary critical care physicians, and Dr. Virapongse, one of our hospital medicine experts. Thank you all very much for joining us today, and thanks to the audience for joining our grant rounds.